start out by prepping the patient. You don't have to be in sterile attire to prep. Prep patient down from knee to mid-belly using circular technique. Once patient is prepped, sterile assistants must put on sterile attire to drape and assist. Once you are sterile, have somebody come and tie the gown behind you. Sterile femoral drape is opened and handed to assistant using sterile technique. There needs to be a table tray placed at the foot of the bed. Once removed, you should see stickers that show right and left and how to align properly on the patient. Using basic human knowledge of directions and anatomy, match the right and left sides with the head and legs of the patient. Remove stickers and place on the groin. Spread open the drape and fold out using the arrows provided on the drape for proper unfolding order. Drape over the table tray. The first items to be placed on the table in sterile fashion are an ultrasound cover, PIC V, PIC A, and ECMO pump pan to begin procedure. To prepare ultrasound cover, use techniques shown. Open cover, insert gel, and place over probe. Important and frequently used items in the ECMO pan are 4 to 6 tubing clamps, Mayo scissors, and needle drivers. Use an extra sterile hemostat to anchor ultrasound to the drape. PIC V wire is longer than PIC A wire. Both dilator kits have the same supplies included. The main difference is the PIC V has 10, 14, and 18 French dilators with Easter egg color ends, and the PIC A has a dilator with an arterial red end and 8, 12, 16 French dilators. Also notice the different shaped containers. We can also use the gray tapered dilators shown on the right. While the surgeon is working on gaining access, place a sterile bowl and bulb syringe. Fill with normal saline. Dump 4x4 gauze onto the sterile field. If placing a distal reperfusion line, open and place a micropuncture kit, a guide wire from Cordis sheath kit, wire reinforced arrow sheath, 7 French use on most patients, 5 French if under 70 kilos, and a male-to-male adapter. If placing a reperfusion line prior to cannulation, the surgeon may want to gain wire access to the superficial femoral artery first. To gain access for the sheath, hand the surgeon the needle from the micropuncture kit. The surgeon will gain access under ultrasound guidance. Hand the guide wire for them to insert in the needle into the artery. Needle is removed. To cannulate for VA ECMO, surgeon will most likely want arterial access first. Without stabbing them, hand the surgeon the needle from PIC A as they are establishing access. Move the cheater up at the end of the guide wire. Hand it to the surgeon, who will then connect and thread. They will remove the needle and the cheater. Next, establish venous access. To do so, hand surgeon and needle attach the syringe, once again without stabbing them. As they are establishing access, prepare the cheater on the venous guide wire. Surgeon will thread. And then remove the needle. With all guide wires in place, heparin is to be bolused, 5,000 units typically, and also 2 grams ANSEF if needed. Communicate this with your surgeon. Safely hand surgeon scalpel. Next, dilate in succession with the smallest dilator up to the largest. While surgeon is dilating, hold wire taut while being mindful not to pull wire out, and communicate with surgeon that you have wire as you pass them the dilators and cannula. ES will hand assistant the arterial cannula, being mindful not to contaminate. Arterial cannula comes out of the package with the obturator attached. Feed through the guide wire and hand to surgeon for placement. While surgeon is feeding through wire, assistant needs to hold red rubber piece and obturator in place as surgeon inserts the cannula to avoid any vascular complications. When cannula is in place, hand surgeon a tubing clamp. Assistant will then pull the wire of rubber piece and obturator all the way out. Surgeon will briefly let the cannula back bleed and will clamp. Repeat same steps for venous cannula placement using the PIC V kit and dilators. Use proper wire technique by keeping the wire taut while being mindful to not pull back the wire. A useful technique is to hold your hand firm on the patient as an anchor to prevent from pulling out the wire. The venous wire is much longer than the arterial, so be mindful of proper technique. After dilation is complete, ES will hand assistant the venous cannula as seen. Assistants should be aware that venous cannulas are much longer and have the obturator separated from cannula coming out of the package. Feed obturator all the way through the cannula and feed through the guide wire. Surgeon may want to briefly measure placement before feeding through. Use similar technique in holding the blue rubber piece and obturator in place as the surgeon feeds the cannula through. While this last cannula is being placed, ES is simultaneously getting sterile lines ready and prepared to be cut and attached to cannulas. When ready, assistant will once again remove wire, rubber piece, and obturator. Surgeon will briefly allow cannula to bleed back and will clamp. Hand sterile ECMO tubing to assistant. Cardiohelp circuit is short, so ES may need to move the console a bit closer to the field. ES clamps reservoir bag and pre and post cone while maintaining pump at 1500 RPMs to promote forward flow. Assistant will clamp the white tape with clamps and will cut as close to the quick connects as possible. If it has been a little bit since placing cannulas, surgeon may let cannulas back bleed before going into wet-to-wet technique. Wet-to-wet technique is used to properly fill and connect arterial and venous lines to the cannulas. Once clamps are removed, ES removes clamps and increases RPMs to reach desired flow and support. Be mindful of color change to ensure sweep gas is turned on. To place reperfusion, use similar steps using the cordis guide wire and arrow sheath. Cut around wire and feed dilator. Use cordis guide wire to thread, then feed arrow obturator. Attach arrow sheath obturator to arrow wire sheath and surgeon will insert into place. Surgeon will open stopcock to prime sheath tubing. Male-to-male adapter is attached and then primed. When ready, ES decreases RPMs to 1500 as surgeon clamps on either side of luer lock connector. White cap is taken off and the sheath is connected to arterial cannula to provide distal limb perfusion. Clamps are removed and ES increases RPMs to achieve desired flow.